Hello and welcome to Differential Discussions. I'm Melissa,
I'm Dave.
and today we're going to look at a slide of G-CSF.
So we saw this quite a bit when where we worked, right? We had a heme-oncology population and pretty common. So G-CSF, what is G-CSF?
Yeah, so let's start with what it stands for. So G-CSF is granulocyte colony stimulating factor.
Mhm.
So
And I remember seeing that in my leukopoiesis lecture.
I was just going to say, so as you're thinking about the stem cell theory and the development of your granulocytes, one of the cytokines that you see is G-CSF, granulocyte colony stimulating factor, naturally in your body that stimulates the production of your granulocytes. So what has happened naturally is manufacturers have manufactured G-CSF so that we can give G-CSF to patients, either neutropenic patients, we can give it to them, or they'll also give it to patients when they're trying to stimulate the push out of the marrow to gather the, all the other cells from them as well. So depending on what's happening with the patient, you can use G-CSF.
So that would be for an autologous transfusion. Is that what you're? I think.
I don't think it's always autologous, but yes, if you're trying to collect like those immature cells, stem cells, things like that.
Really cool procedure.
Yeah.
So I think most often I saw this, or at least you notice, right? The oncology clinical call, and they'll be like, "Hey, what's the ANC on so and so?" And then you start looking. Oh, I'm reviewing that right now, and then you see toxic gran and Dole bodies, and so.
So your chemo patients trying to push up their neutrophil count so that they can go home.
Go home. Yeah, exactly. So this is a pretty good example of the sort of toxic granulation that you may see with patients that have been recently given this therapy. So the other things that we might expect too is some kind of a left shift.
Yep.
So as we might cruise around, we're going to look for more immature granulocytes, things like that.
Toxic gran, Dole bodies.
Yep.
Left shift, those are usually the things that you see. I don't know what we'll see in this one, but you could see all of those in patients with G-CSF.
Yep.
Okay.
And as you scroll around, I'll note that there appears to be some socytosis. So this individual may be getting blood transfusions or, is that a Bezo?
It's a Bezo.
What's up, Bezo? Love it.
Yeah, so I saw him when I was cruising by and I wanted to stop because this is not toxic granulation.
Right. Absolutely. And I say it all the time, but the color of the cytoplasm is just different than a neutrophil. It's like really, really subtle, but it's I'm tuned in.
Well, it has to do with those soluble contents of the granules.
Right. And so this Bezo maybe doesn't have as many granules as maybe other Bezos that you've seen. And part of the color of the cytoplasm is maybe those have kind of dissolved and kind of bled into the cytoplasm a little bit. Really cool.
Well, just look at the size of this red cell here.
Yes. Yep. I really wouldn't be surprised if so every now and then we encounter, and it's usually with a transfusion, a patient that's received a transfusion. Oh, perfect. So we see myelometa, I guess, depending on how you want to stage this. So this is a really good immature granulocyte.
Yeah, I'd probably go, with a meta.
Yeah, that's what I was thinking, because you get the flat side and a little.
Yeah, and the chromatin pattern is more mature.
Yep. Mm-hmm.
This one's got a little bit of toxic granulation, this neutrophil.
Yep.
It's not as toxically granulated as the last one that we saw, but it does have some toxic granules.
Yep.
So
yeah, on the red cell populations, if you have a person that has naturally perhaps microcytic population of cells for one reason or another, whatever is going on, and then transfuse with a lot of blood, and those happen to be normal red cells, you'll see your your histogram of your red cells will have two distinct peaks. Oh, cool. What's going on with this fella?
Yeah, so this guy, it looks like his granules are all just pushed off to the side, and so this part of his cytoplasm has no granules really in it.
So this is a good moment to kind of learn about what does a cytoplasm look like when there's nothing in it. And so on occasion, you'll encounter, usually oncology patients in my experience, but they'll have neutrophils that have no granules. They're either agranular, nothing, or hypogranular, and you'll see this ghosty blue cytoplasm. But the nucleus, darn it, it looks just like a neutrophil's nucleus. So we're seeing something of that here, although most of the cytoplasm is well granulated.
Yeah.
Really cool.
They look normal.
Yep. At first, I thought there might be too many segments, but
no, they're okay.
Yeah, they're fine. So another thing that you might see in a patient that's getting chemotherapy, another immature gland. So would you say this is myelometa again?
Yeah.
Yeah.
I think he's a myelo.
Yeah.
But, I don't think anyone would be really off if they said meta.
Yeah. So this is interesting too. I think for a student, maybe just learning immature granulocytes or not knowing about immature granulocytes, someone can call this a lymph quite easily, don't you think?
Especially this one.
And
it could be like, well, this color's a little bit off, but overall it looks like a lymph.
So what I'm seeing in the two immature granulocytes we've seen so far is it's not like a super pink cytoplasm. It's got a bluish kind of undertone to it. So making it a little bit trickier to make the call.
Yeah.
But I was talking about hypersegs earlier because some chemotherapeutics that patients might get. Oh, interesting. So now we have a lymphocyte. So one of the biggest differences I see between these two things too is if we just ignore the cytoplasm and we just look at that nucleus, how dark is that chromatin pattern, right? Very consistent with a fully mature lymphocyte. Whereas our immature granulocytes, they haven't fully grown up yet, right? They'll still have a less mature chromatin pattern. But some chemotherapeutics are, what are they, like folate?
Antifolate.
Yes. And so you can, while treating a cancer, you can develop a sort of controlled megaloblastic anemia.
Yep.
Look at these two.
Yep. Beautiful.
So awesome toxic granulation in that lower cell, juxtaposed to a fairly normal looking neutrophil. Yep. And are there, no, I was going to say, are there Dolly bodies maybe, but it's hard to tell. Maybe not.
No Dolly.
I'm not going to overcall. You can will some of these inclusions into existence sometimes.
Right. Just looking at it and you're like, yeah, it's there.
You just want it to be there or expect it to be there so much.
So he's just another one with a little bit of toxic gran in there.
Yeah, it's like medium toxic gran.
The other thing is this looks like 3 separate nuclei, like they're not touching each other.
It looks like there's some kind of filament, but maybe I'm missing it.
No, it looks like there's one here.
Yeah, I see that one. Yep.
This one, you can't really see it.
We'll have to just presume.
They're easy to miss, but neutrophils always have these little teeny filaments that connect them. So they are segmented. It's not separate nuclei.
Right. That would probably be a poetic feature, honestly, if you saw distinct separate pieces of nuclei in your neutrophils.
Yep. Another beautiful toxic gran.
Very nice. Ooh. What up, Bezo?
And so we've seen a couple of bezos now, and I just want to point out that it's G-CSF, not neutrophil colony stimulating factor. So there can be other granulocytes as well.
Yep. Excellent point.
This is a really nice example of the filaments that connect the nuclei, the separate lobes.
Awesome looking cell. Right on that border of normal for segments, just saying.
Let's pull that last neutrophil in.
Yeah.
Nice toxic gran here. Normal-ish looking neutrophil. He may have a couple of toxic granules in there.
Yeah, yeah. Less than his buddy. Hello. So basophilia, perinuclear halo. I'm thinking some kind of reactive plasmacytoid lymph.
But wait, he's not reaching out and touching. How's he reactive?
Yeah, it's I gotta be honest. I mean, a lot of times when we use like terms to describe stuff, it gets a little hazy and kind of, what I can see is that this one is wanting to maybe go to like plasma cell to want to terminally differentiate as perhaps a B cell. That's what I'm guessing. I would probably call this one. I don't know about you, but
yeah.
Yeah.
No, I would. He's really nice and reactive looking. He doesn't look like a downy type reactive lymph,
right?
The stretchy one, but he's still a reactive lymph with the deep dark basophilia in the cytoplasm. It's pushing the nucleus off to be eccentric. Like Dave said, it's plasmacytoid. He's probably moving towards a plasma cell, but this is another type of reactive lymphocyte.
Yep.
Is that related to G-CSF?
I don't think so personally, but they shouldn't be responding to G-CSF. But I'm willing to admit I'm in a cone of ignorance because cytokines have complex consequences.
Sure.
So it could be that signaling neutrophils could have further but no, I would say it's not related.
No, the G-CSF itself won't instigate the lymphocytes to doing something.
Right.
And then this one looks like it's toxic granulation.
Yes. So I could see someone at a glance look at this and maybe think baso, right?
Yeah.
Because sometimes toxic gran can look a little chunkier. Those granules can look a little bit chunkier, but the color is off. So that to me, that's neutrophil all the way.
Yeah. The other thing that makes sense with the reactive lymphocytes and cancer patients is that a lot of times cancer patients are obviously really prone to getting other infections, especially viral infections, general viral infections like cytomegalovirus that are like nothing to you or I because we're competent is severe and can really cause an illness in those compromised patients. So it could be that this patient is experiencing some kind of viral infection in addition to having their immune system really compressed by chemotherapy or whatever else is going on with the patient.
It's a good point. A lot of these cancer patients are fighting multiple fights. They really have to guard themselves against infection. They're so vulnerable. Nice sphere site.
Oh yeah, nice corner here.
So this patient looks like they have a pretty decent ANC. You think they would go home?
Yeah, definitely. They've probably been there for a couple days waiting for that ANC to go up, though.
Yeah, it's true. Yeah, it's true.
All right. Well, I think that's all we have for this video, so thanks for watching.
Thanks for your time.
Please like, subscribe, and hit the bell if you'd like notifications whenever we post a new video, and feel free to reach out to us on social media or via email with comments or suggestions about future content. Thanks.